Okay. Okay, so hi everyone. Good morning. Welcome to today's CME. My name is Jimmy Njoroge. I am a level 5 medical student at the University of Nairobi. I am also a BSc Anatomy graduate, class of 2021. I have a passion for academics and anatomy, surgery, and football. So if after this you'll be going to watch a Manchester United game, just know I will be there. Anyway, on behalf of XYZ Medi, welcome to this session. XYZ Medi is a vibrant community of Kenyan medical students from multiple universities, united by the mission to enhance medical education in Kenya. And this initiative is driven by the need to create accessible, locally relevant, and tailored resources that directly address the country's unique healthcare challenges. Therefore, it is necessary to create content that is relevant to our local context. And that is why we have initiatives such as quizzes, healthcare stories, lectures, and thank you for joining us. That's for the people who have not joined us before. Thank you for joining us. Today's CME topic is sepsis, and our speaker is Muhia Ng'ethe. Muhia Ng'ethe is a level 5 student at Kenya Methodist University. He states that he has a strong passion for surgery, and his future goal is to become both a skilled surgeon and a medical lecturer. Outside of academics, he's also an avid sports enthusiast, and he enjoys both watching and engaging in lively sports banter with friends. I see that birds of a feather flock together. Anyway, karibu sana Moher. I'll let you present your screen and you can get started on your presentation.
Okay, thanks, Mr. Gakure, Jimmy, for the kind introduction, and good morning, everybody. Before we get started, please confirm that I'm audible enough and that you can see my screen on your side.
Yes, Moher, we can hear you and we can see your screen.
Okay. Are the slides moving? Please confirm.
Yes, they are.
Okay, so let's get started. I'm sorry for the delay, but let's get started. It's a very short lecture or short talk that will take the least time possible. So I'm Muhia Ng'ethe, as you told, and I'll be taking you through sepsis and septic shock. To get us started, I have a brief case study where we have a 32-year-old female, an engineering student who presented with a 5-day history of fever that was high grade, associated with chills, throat pain. The patient has consulted two doctors with no relief. When checking her vitals, the patient was tachycardic, tachypneic, hypotensive, and was saturating at 96%. Her temperatures were elevated at 38 degrees Celsius. On examination, the patient had bilateral tonsillar enlargement with pus pointings. So the big question is it sepsis or not? And we'll get to answer that in a few. So now before we get to know what sepsis is, we need to understand some key definitions and how they differ from sepsis. And uh, on a light note, I'd like to say that I'm going to be biased. Sepsis can be caused by any pathogen, be it a virus, fungi, bacteria, but for epidemiology, it has been noted that sepsis is mostly commonly associated with bacterial infections. So I'm going to lean more on bacterial causes. For the definitions that we need to know is how to differentiate bacteremia from septicemia from sepsis. So when we have bacteria in the blood without any signs and symptoms of infection, that's when we call it bacteremia. But when the bacteria starts to divide and multiply while producing toxins that develop signs and symptoms of an infection. And that's what we call septicemia. When the septicemia isn't dealt with, and the host immunity mounts an exaggerated inflammatory response, we get to sepsis. And it's worthwhile noting that there is a thin line between septicemia and sepsis. So when we need to act very fast when septicemia is suspected, not to develop sepsis. I hope that was clear. So the definition of sepsis has been evolving through the centuries, all the way from 750 AC to the latest one in 2016. In the early 90s, sepsis was defined as a systemic inflammatory response syndrome, and it had to meet two or more of the following criteria for a diagnosis, where the patient had to have a temperature either below 36 degrees Celsius or above 38 degrees Celsius, had to have a heart rate greater than 90 beats per minute, a respiratory rate greater than 20, or partial pressures of carbon dioxide less than 32, WBC count less than 4,000 or greater than 12,000 or greater than 10% bands. That was in the early 90s. In 2000, sepsis, they decided to coin two new terminologies. That was severe sepsis and septic shock, where they defined severe sepsis as when sepsis progressed into organ dysfunction and tissue hypoperfusion with hypotension. And they also coined a new term called septic shock, where they defined it as organ dysfunction that persisted despite volume resuscitation. However, in 2016, they decided to drop the term severe sepsis and redefine sepsis as a life-threatening condition caused by dysregulated host response to infection resulting in organ dysfunction. What they just did is that they did away the severe sepsis and decided that sepsis should have organ dysfunction. And they also tweaked the definition of septic shock to refer to when sepsis persisted despite fluid resuscitation requiring vasopressor therapy. Why I took you through this roller coaster is because as the definitions were evolving, also diagnostic criteria were changing. So it's important to know how we came to have sepsis and septic shock. The risk factors for sepsis, one of the major risk factors is age. Here, I forgot to add something. Age is usually extremes of age, the very young and the very old. Those people who are rotated in pediatrics can confirm that in neonatology, one of the complications that neonates usually suffer is sepsis. Patients who have serious injuries, especially those who have burns, extensive burns, patients who have chronic debilitating medical conditions, the immunosuppressed, patients with indwelling vascular catheters, especially those in the ICU, they are monitored very closely for any signs of sepsis, and patients who have recurrent UTIs. For the pathophysiology that is involved in sepsis, we start with the patient getting an infection, whether in the hospital or at home in the community, from different pathogens, varying from bacteria, fungi, various or parasites. And then the innate immune response is activated, leading to features like having a high fever, leukocytosis, leukopenia, left shift, or bandemia. And due to this response, a compensatory mechanism is initiated, leading to patient developing signs like tachypnea, altered level of consciousness, and hypotension. This hypotension is mostly brought about due to the vasodilatory effect of the sepsis. The vasodilatory effect will lead to most of the complications that we have. And because of this compensatory mechanism, the patient develops decreased perfusion and oxygen delivery to organs, leading to organ dysfunction. Some other risk factors, patients who have comorbidities like splenectomy are infected with pathogens that have high virulence and have vulnerable infections, and they have a regulated host response where the pro-inflammatory response overpowers the anti-inflammatory response. I think this arrow should have come here because this inflammatory response will lead to decreased oxygen delivery to organs, leading to organ dysfunction. And saying organ dysfunction, it can affect any organ in our bodies, starting from our respiratory, nervous system, cardiovascular, liver, kidney, or coagulation, the coagulation. So, but this is not in the order in which we are affected. The kidney is usually the first organ to be hit, followed by the CVS, but there are many literatures out there that have different approaches. And when you have a patient with sepsis, you try to resuscitate the patient with fluids and it fails. Their mean arterial pressure is less than 65. Their tissues are hypoperfused, leading to increase in the lactate levels. This patient has gone into septic shock and requires vasopressor therapy. I hope the physiology was also clear. So sepsis has two processes in each. We have the dysregulated host response and the organ dysfunction. And the process, the inflammatory and the organ dysfunction, have different criteria of diagnosing them. The inflammatory process, we use the SAS criteria, and the organ dysfunction, we use SOFA criteria. So SAS
Hello,
criteria,
Mohia. Sorry
yes,
for interrupting.
yes,
A participant stated that the audio clarity wasn't so good. Will it be possible
okay.
to improve it?
Let me try.
Yeah, sorry for that interruption.
It's okay, it's okay.
Just the
So,
audio, not the slides.
okay, Jimmy,
Yes,
can you hear me clearly now?
yes. Now I can hear you well. That's good.
Oh, I'm sorry for that. So,
So,
where did
thank you.
where did I lose them?
I think it was just the slide before.
Or when I'm talking about the SARS and SOFA.
Yeah, yeah. So I think you're good. You can proceed.
Okay, I'm sorry for that. So for the sepsis, we said that there are two processes. I'm going to repeat this slide. So we have the two processes that are happening together, this dysregulated host response and the organ dysfunction. And we have two criteria that can be used for diagnostic of the two. We have the SARS and the SOFA for each process. But many literatures out there are trying to phase out the SARS criteria. And later on in the slides, I'll show you why I personally am not for them phasing it out. So the SARS criteria, we had gone through it and the 5 parameters that are used. For this Q software score, I want you to ignore it for now. I'm going to come back to it later. Yeah, now we have the SOFA. The SOFA criteria, which stands for the sequential organ failure assessment score, is a very intricate scoring system. And to be honest, I only can recall a handful of the parameters, especially when put on the spot by a consultant. But what you can't be forgiven for forgetting is the parameters we use for different organs. That is, in the respiratory system, we usually use the partial pressures of oxygen over the FiO2. In the coagulation, we use the platelets counts. Liver, we use the levels of bilirubin. The CVS system, we use the MAP and the type of ionotrope or vasopressors that is used. And the central nervous system, we use the GCS score. Excuse me. And when I said that I have a grasp on a handful, I was meaning the GCS because it's the easiest of them all to understand. In the renal system, we have the creatinine levels and the urine output. The urine output being a major parameter. So I have an algorithm that will help you to approach any patient with suspected sepsis. When I told you to forget about the Q software, I want you to remember it because the software, as you have seen, it's a very detailed and difficult scoring system to cram or to remember on the spot. So they developed the Q software where you use the respiratory rate, the mental status where you use the GCS, and systolic blood pressure. So by using this, if you get 2 out of 3, the patient is suspected to have sepsis. It's not a definitive scoring system. It's not that sensitive, but you have suspicion that this patient is probably having sepsis. So when you have a Q-SOFA greater than 2, yes, so this patient is maybe having sepsis. What do? You go and assess for evidence of organ dysfunction. So you use the SOFA scoring. If you have a SOFA score greater than or equal to 2, using the different parameters, then the patient is definitely having sepsis. And if you try to resuscitate the patient with fluids, it does not work, and you need vasopressor therapy, then the patient has developed septic shock. But if you do the quick SOFA score and it's not greater than or equal to 2, sepsis, you are not sure that, you don't say that the patient is not in sepsis. What you can best do is closely monitor this patient regularly as much as possible, or you can also go directly and do the SOFA. If you suspect this patient, the Q-SOFA is not that definitive, and you see that it's 1 out of the three, just go ahead and do the SOFA. Okay, I hope I was clear with that with the Q-SOFA. It's not a sensitive scoring system, but it's usually used to help you in a casualty setup where you don't have the lab values that coming back, but this patient needs to be treated with care. So when do we say that using the SOFA scoring score, when do we say that the patient has an organ dysfunction? This is when the patient has an acute change in SOFA score greater than 2 consequent to infection. This is just saying, if let's say a patient comes to you and you diagnose the patient to have pneumonia, pulmonary pneumonia, then you take the SOFA score, it's a 0. Then a few hours later, you come back, do the SOFA scoring, and you see the patient has a SOFA score of, let's say, 3. Then this patient has definitely have organ dysfunction and has gone into sepsis. And a SOFA score greater than or equal to 2 reflects that the patient has an overall mortality rate risk of 10%. This shows the more the score, the higher the chances that the patient would make it. So now going back to our question, is the patient in sepsis or not? So for us to diagnose sepsis, now we go for, is the patient having an inflammatory process going on? And that can be diagnosed, diagnosed using the SARS criteria, where we have, yes, the patient is tachycardic, he has greater than 90 beats per minute. The patient has a high-grade fever, greater than 38 degrees Celsius. The patient has a respiratory rate greater than 20. So the inflammatory process is going on. So the next question, does the patient have an organ dysfunction? Using the SOFA. Using everything that we have here, the only thing that we can use for checking if the patient has any organ dysfunction is the pressures, and where we can calculate a mean arterial pressure. And because I know all of you have an MD calculator, this will end up having a map of around 70 milligram mmHg, and this is a score of 0. So this patient does not qualify to have sepsis using the 2016 definition. So what do? We need to evaluate for any other organ dysfunction. We don't say that the patient is not septic. We are not sure because we had only one organ to assess. And that's why we need to go back and check if the respiratory system is affected, the liver, is it affected, the GCS, is it affected, or the renal. So the answer to this is we are not yet sure because we have little information. Okay, you remember when I said that the SARS criteria was being slowly phased out? This study was done, I think it was an article published by PubMed, where they said when SOFA criteria was used alone, it delayed administration of antibiotics. And when the SARS criteria was used alone, the identification of sepsis, the identification of organ dysfunction in sepsis was mostly missed. So I personally, or you guys can go and consult your consultants and ask if Is it possible that we can still have the SARS criteria to be used in 2024? But this study says that it's better to use both of them. So septic shock, we had defined it as when we have circulatory, cellular, and metabolic abnormalities in septic patients. This is when the patient has persistent hypotension despite fluid resuscitation, and the patient had to have vasopressors to maintain a mean arterial pressure greater than 65, and the patient's lactate levels were greater than 2, indicating that there was tissue hypoperfusion. Okay, how do we evaluate and manage patients who have suspected sepsis? So the immediate evaluation and management needs that we stabilize the respiration, establish venous access, and initiate vital investigations, okay? These are usually in most emergency setups. These are the first things that we always do. And we have to administer empirical antibiotics. The Surviving Sepsis campaign launched the 1-hour bundle as an initiative for the management of both sepsis and septic shock to reduce mortality rates. It's composed of 5 elements that need to be initiated within the first hour from time 0 or the time the patient presented. These elements are: we measure the lactate levels, obtain blood cultures before administering antibiotics, administer broad-spectrum antibiotics, begin rapid administration of fluids, that is 30 mL per kg crystalloids, and apply vasopressors if hypotension persists. So we shall talk more on some of the elements. We shall talk more on some of the elements as we continue. When taking the blood cultures, you need to always remember to take it before starting the antibiotic therapy. And when you're taking the blood cultures, always remember to take 2 sets, one for the aerobic and the anaerobes, okay? Remember, take blood cultures before antibiotic therapies started, and 2 cultures for the anaerobes and aerobes. And so for the resuscitative therapy, when you start to resuscitate the patient, the goal is to achieve tissue perfusion, to have source control of the infection, and decide where the patient needs to be admitted, with most cases requiring ICU admissions. And we are cautioned here not to follow guidelines blindly, because I know different hospitals out there have different guidelines on how we resuscitate our patients, but we don't follow our guidelines blindly, and we'll see why. Okay, so for resuscitation with fluids, when we give fluids, you need to decide on certain issues. One of them, do you give crystalloids or colloids? And crystalloids are preferred because they do not exert oncotic pressure in case of that spacing due to the vasodilation that is occurring in the sepsis, okay? And balanced crystalloids are preferred when you're giving a large volume of fluids, that is approximately greater than 1.5 to 2 liters. When you're giving that large amount of volume, balanced crystalloids like Ringer's lactate is more preferred than salines, not just isotonic, even the other salines. And the balanced crystalloids have a less chance of causing kidney damage and less chances of developing metabolic acidosis. And it's always wise to consider albumin, 5% albumin, when fluid requirements is too much. As I said earlier on, different hospitals have different protocols, but universally, the volume used is 30 mils per kg. That's mostly for adults. I think the PIDS protocol says around 20 mils per kg, unless the patient is contraindicated to fluid therapy. And this contraindication to fluid therapy is mostly patients who have pulmonary edema. So before you start fluids, it's good to do a chest X-ray, auscultate the chest for any rales or crackles to confirm the patient doesn't have pulmonary edema, because the fluid therapy will just worsen the condition. Sorry for that. Whether to give large volumes or low volumes can be assessed using the following flowchart. Yeah, where you assess the volume status of the patient, where you take the clinical history, you check if the patient has known cardiac dysfunction, bedside echocardiogram, and you check if the patient has increased risk of harm from hypervolemia. And when you assess that, when you get the different history and everything, you decide if the patient can take large volumes where you give 2 to 4 liters, or the patient can take moderate volumes, 1 to 2 liters, or low volumes. I'll share the slides so you can check out this flowchart here. Yeah. So as I said earlier, bacteria is the most common pathogen to cause sepsis, and an empirical antibiotic therapy should be started as soon as possible, because source control is always a major step in management of sepsis. And this can be achieved by giving antibiotics. But again, what antibiotics do you use? So when choosing the antibiotic, it's always wise to use a broad spectrum antibiotic. Yeah, it's better to use multi-drug regimens and use the highest dose of the antibiotic the patient can tolerate. That is, if antibiotic has a dosage of 50 to 100 milligrams, it's wise to use the 100 milligrams than to start with the 50 and slowly titrating the patient. And the specific antibiotic to use is dictated by the following. What is the site of the source of the infection? Has the patient had previous antibiotic use? Is there local susceptibility patterns? Is the patient immunosuppressed or risk for resistant organisms? So the dosing, I've covered it. We've used the highest dose possible. And different sites have different bacteria colonizing them, as evident from our microbiology. And this necessitates that we have different antibiotic regimens for different sites. Like in the skin, we know Staph aureus is the most common bacteria. But when you go to the urinary tract, we have E. coli and Proteus. Okay. So, and I won't bore you with the nitty-gritty of all antibiotics for the different sites. Like we have sepsis from pulmonary sources where we can use all these antibiotics. We have sepsis from the biliary tract infection, sepsis from other sites like the catheter-related sepsis and so on. But I will take exception to sepsis caused from unknown source, where you find yourselves without an origin of the infection. Then when you have such a scenario, the antibiotic of choice are carbapenems if you're going to go for monotherapy, with anti-pseudomonas penicillins as second line. But if you decide for a combination therapy, we can use metronidazole plus aztreonam or cefepime. Okay, but as I said, I'll share the slides. You can go through this list and the different antibiotics. Okay, and after you administer fluids and antibiotics, you always monitor for response. How do you do that? How to monitor for response is to check if the patient is hemodynamically stabilizing and all organ dysfunctions are resolving. This table can assist you to check if the patient still has signs and symptoms of hypoperfusion, and equally assess that you are not doing too much, causing the patient to have fluid overload. So if the patient is having systolic blood pressure less than 100, the MAP is less than 65, the heart rate is greater than 90, shock index greater than 1, and elevated serum lactate, then this patient is still not improving, and there's no response. So you need to do more. But while you are doing more, you need to check that the patient does not develop pulmonary crackles, or you do a chest x-ray to confirm the patient does not develop pulmonary edema, the patient has no increased jugular distension with fluid administration. Okay. And so after administering fluids and antibiotics, and the MAP is less than 65, and lactate levels are greater than 4 millimoles, we have entered into the belly of another beast, and we require to start vasopressors start, and the patient is now in septic shock. Okay. And when we go to the vasopressor route, you can start with peripheral vasopressors, but if requirement escalates, then transition to a central line is required. And so, but I have a controversy, which you can also share with your consultants. Since we aren't following guidelines blindly, there's a new study that is questioning the guideline that tells us that we start fluids first, then vasopressors later, because the longer the patient is hypotensive, the higher the risk the patient is for developing renal failure. So my question is, do we give fluids and vasopressors and ionotropes simultaneously, or do we just follow the guidelines that are set there? That is another controversy that you can gladly share with the consultants in different hospitals. Okay, so here we can see how we go about choosing a vasopressor with norepinephrine preferred over vasopressin, and norepinephrine preferred over vasopressin and adrenaline. That's because norepinephrine is mostly a vasoconstrictor and increases the systemic vascular resistance that is usually affected by the vasodilatory effects of sepsis. Other possible choices is phenylephrine for patients who have AFib and VTAC. Epinephrine can also be a first-line choice in patients with bradycardia and signs of decreased cardiac output. And here, if you go for epinephrine and vasopressin, here we have the yin-yang between vasopressin and epinephrine, where a combination of both offers better outcome due to their different but synergistic effects in septic shock. Okay, and finally, okay, what's happening here is that the role of steroids in septic shock is not fully understood, and there's different people have come up with different ways to approach it, but studies have come to support that patients that have refractory to low to moderate doses of vasopressors, those patients who are on vasopressors on low and moderate doses, and they are refractory, they have shown that when you give steroids, it decreases the mortality rates. So the steroids have started to be introduced when patients have developed septic shock, and it has shown to decrease the mortality rate. And that is all I'm going to say about this, because it's also under review and studies are still being done on it. And I would like to thank you all for giving me your time. Jimmy, back to you.
Thank you, Dr. Ng'ethe, for that amazing session. I think I'll give this opportunity to our participants. If you have any questions, feel free to ask them. You can unmute once you raise your hand, or you can send your question through the chat box. We'll allocate about 7 minutes for that. So at 12:08, we'll proceed to the next phase of our CME. So if you have any questions, feel free to ask them.
Hello.
Hi, Doreen. Okay.
Hello. Hi. Yes, how are you? Yeah, I
We're
have
good.
a
We're good.
question. Am I clear? Yeah, okay. Thanks for the presentation. It was really profound. Yeah, but maybe I didn't capture it well. Would you mind clarifying? Now we have the Q SOFA and the SOFA. So I wanted just to know, so currently, right now, so which is the preferred criteria now for diagnosing? Are we using the Q SOFA, or we still go back to SOFA, or we can combine them? So which one do we use now currently? Thank you.
Okay, Doreen, thank you for the question. For the Q sofa, as you saw, okay, let me share my slides again. Sorry. 1 minute. Jimmy, are my slides visible?
Yes, they're visible.
Okay, here. Doreen, as you can see, for the SOFA score, most of these parameters are lab dependent, except for maybe the GCS and the mean arterial pressure, where you can do it in a setup like in a casualty, where you can take the pressures and calculate the mean arterial pressure, and the GCS where you can do it, okay? But the other ones are lab dependent. So it might take you time for you to get the results. That's where the Q software comes in, where you can do everything. Let's say a patient comes in a casualty. You see that you take their history, they had a history of pneumonia 2 days prior. They were diagnosed with community-acquired pneumonia, and it was mild, and they were discharged. Now they are back they are back in the casualty, and they are hemodynamically unstable. Their pressures are low. That's where the Q software comes in, as you give your labs to go, your blood to go to the labs. So the Q software will help you. It's it has low sensitivity, but it will give you an idea if the patient is septic or not. But ideally, the SOFA is the ideal scoring system. So do the quick SOFA as you are giving the blood to the lab to do the evaluation test. And if the Q SOFA comes to be 3 out of 3, then you have the 1 hour bundle in mind, so that even if the labs are not back, I know you can start now giving the patient, you start measuring the serum lactates, obtaining blood cultures as you did it, and administer broad spectrum antibiotics. I hope I'm clear.
Yes, thank you.
Okay. Any other question?
Yeah, keep asking your questions. You can unmute or you can use the chat box. You can also send your comments on the chat box, comments regarding the presentation just made. I can see Emmanuel Alk said that they're often administered simultaneously. I think he's referring to the ionotopes, the vasopressors, and the fluids. Okay. Let's see. Nothing so far in the chat box. Still checking it out. Ah, wonderful. Thank you, Emmanuel, for that clarification. We still have about 1 minute to deal with questions. Okay, if no one else will be...
Jimmy?
Yes?
Oh, okay. I have a question. Maybe everybody can look it up later.
Okay. Okay.
So, guys, if the patient has a viral induced sepsis, the patient has viral induced sepsis, how do you go about the management? Is it different from how we have approached it, or do you do it the same?
Well, that's a really insightful question. I'm sure everyone will go look it up. From the top of my head, I can already think the approach may be different since the antibiotics used will not be helpful. The ones that you indicated, they're mostly bacterial. So I'm assuming you'd have to know the viral cause and know how to deal with it. Other than that, I think the supportive management may be similar, but I will read it.
Thanks for the feedback.
Yeah, we'll go check it out. Okay. I think since no one is asking any more questions, we can proceed to the next part of our CME over the next few minutes. Andrea has been our administrator for the day. Thank you so much, Andrea, for your participation. I'm calling upon you to help me present the next phase of our CME, which is the Kahoot session. Thank you, Andrea. These are the unsung heroes. He won't talk as much today because he's behind the screen, but he's a really helpful part of this session. So, what we're about to do next is to play Kahoot. It's a really short session. Please join. Here's our game pin, 818-8443. Join at kahoot.it, or if you already have the app, you can use it. So I'll give you guys about 3 minutes because we are quick. 3 minutes to sign in, and then we can begin. Yeah. Um, this is a bad joke. Just you can let it slide. So technically, because we are in this together, we are in cahoots. Anyway, moving on. Huyu mtu wa bad joke ni nani? I like this guy. Yeah, keep signing in, guys. There may be a prize for the person with the most interesting nickname. I give no promises. I'm just saying. Yeah, Loch is a funny guy. So far, we have only one, two, three, four, five. And I have 5 participants. There are about 18. I expect at least 10. Ni kama tutacheza Kahoot watu watano. Elut. Mkurugenzi. Okay, we'll start at 12:13. I'm hoping by then everyone who's interested in joining will have joined. Nice. Let's keep joining. Let's keep joining. 1 more minute. It's almost 12:13. Hey, I think one person just left, so we can begin at 12:13. That's in a few seconds. Let's keep joining. Let's keep joining. Good, it's 12:13. I think we can begin. We are locking it. No one else can join. Let's start. Hii kitu ni kama sport bwana. Nice one. Yaani ni mtu mmoja pekee alikuwa anajua my lord. Hey. Eh, I wonder. So which one is not considered while calculating the sofa score? I hope mlikuwa attentive kwa darasa. We? Oh, at least hapo points will increase. Nice one. So biomarkers of sepsis, all of them are acute phase reactants except Mhm. There's a part where you ask yourself, what are acute phase reactants? So which is not part of the 1 hour bundle. Hmm? What is the 1 hour bundle? How do you assess the volume status of a patient before fluid administration? Good. Ah, the race is tight, bwana. Kuna mtu ako 300 points ahead. So when are balanced crystalloids used? Hmm? Nani alikuwa attentive? Nani alikuwa attentive kwa darasa? Hey, Jogoo jijini is on fire. Nice one. Let's go. Which organ fails fast when sepsis progresses? Hmm? Tulete hizo majibu. Tuone nani the winner. First line was oppressor of choice. Nani alikuwa keen kwa darasa? That joke is on fire. Nice work. Which one isn't a criterion for sepsis in SARS? Hmm? Tuone nani ako serious? Nani alisikiza? Yani kila mtu alipata hii swali wrong. My lord. eh, med school ni ngumu. So which antibiotics are used to treat sepsis from an unknown source as first line? Jo mliambiwa you won't be bored by the nitty-gritties. So ndio hiyo podium. Number 3 ni Jogoo wa jijini. Number 2, bad joke. Number 1, and the undisputed champion of the day. Time. Yeah, congratulations my guys, congratulations. Hatutataja wenye hawako kwa podium. Number 4 na 5. Nyinyi mtulie tu huko. Maybe Type can tell us who it is, but Joe can tell us who it is, and Jogoo wa jijini can tell us who it is. Nani Type? You can just
hello.
unmute or
Mi
raise
ndio
your
type.
hand.
Hello.
Oh, ni nani? Who's that?
Nanisikia?
Yes,
Ndegwa,
nakusikia.
Ndegwa. Mi ndio type
Ndegwa.
sasa.
Nice. Nice one, nice one. Congratulations, Ndegwa. Nice game. But
Mm.
joke ni nani? But joke ni kama hataki kuonekana. Ama ni mwalimu wa leo? Sala.
No.
Si wewe Muhia si wewe Bajuk.
Not me, not me, not me.
Oh, tuna confirm tu. Unajua saa zingine watu wanaingianga wanajipea medals. Yaani wewe umeset exam.
Not really.
Haya, sawa. Bajuk ni kama ameamua kuwa chivalrous. Haya, Jogoo wa jijini. Who is there? Jogoo wa jijini. Kwani where are these people? Titenda wema nenda zako. Come win and leave. Oh, sorry, we are transcribing. Oh, who are these people who are winning and leaving without telling us? Who are these people? Anyway, thank you so much for joining us for Kahoot. Thank you for being part of today's
If I
session.
may
I know it's a
interrupt you,
Saturday. Yeah, it's okay, it's okay.
and Degwa, since I joined this XYZZ series, has always been on the podium. I think you guys should do something for him.
Oh, yeah. Oh, for real. Nice,
Ndego has
nice.
never
So,
missed the podium.
Nego is a church student. Malipo ni dunia ni mbinguni. It's okay, we'll talk about it. Ati misheveve. Oh, tumezo misheveve. Ndego, look for. I'm not telling you to look for me, but uh, keep doing what you're doing. You're doing well. Ah, anyway. Anything else? Anyone with anything to say? Any comments?
So for me, I joined the meeting late. Can I get the recording or?
Hello, Mark. It appears your audio is a bit low. Will you improve it, kidogo? I can barely hear you.
So can you hear me well now?
I can hear you a bit better, but sauti yako inasound ni kama ni ndogo.
Uwi. Yes. Na sai.
Bado. But okay, unaweza tuambia tu.
Oh, so I was saying I joined the meeting late. So maybe can I like get the recording of the session so I can pass through it.
Okay. Okay, so thank you for that. We have recordings that are sent through our XYZZ channel. You can always speak with Felix or Andrea regarding that if you haven't joined our channel yet. We always have recordings and we also have a YouTube page. So you always find recordings of our CMEs from there. So usishtuke just to a recording. It is available on the internet. But thank you for that communication. Any other comment before I officially close this session? Okay, if there are none, thank you for joining us today. Thank you for spending time over your weekend to come and listen to this CME. It's something that we really appreciate. If you're interested in joining XYZZ in any capacity, as a moderator or as a speaker, or even in other facets of our community, like research or lectures or quizzes, feel free to reach out to us. We are available. We are also looking for new people. So you can always join us and participate. Otherwise, see you next week. Enjoy your weekend.